Hello, my name is Carissa Gashi, and today I'm going to discuss my clinical case study. Here we go. So let's start at the beginning of patient M.L. The primary diagnosis was duodenal adenocarcinoma. So prior to admission to the emergency department, she had a chemotherapy regimen that had begun 4 weeks prior to admission. The patient reported that she had spent the past 3 weeks completing chemotherapy, and then the last week she had off. During her off week, she developed worsening nausea and vomiting. The patient was admitted to the oncology floor and was treated for leukocytosis related to the duodenal carcinoma. Some general information about my patient will include that she was admitted to Providence St. John's Hospital in Santa Monica, California, on the date of October 30th, 2018. She was diagnosed with leukocytosis, post-chemotherapy, and secondary for duodenal adenocarcinoma. She was a 45-year-old woman who is not Hispanic or Latino nationality. She was married, she lives at home, and she has a caregiver. Under her family history, there is one maternal grandmother that had bladder cancer, and the patient had a mother who suffered from drug abuse and a cancer type unknown. There's no other history of depression or anxiety. Some more general information that we would need to know to begin is the patient weighed 86 pounds and she had a BMI of 15.6. The BMI is considered severely underweight. The patient had already been on a tube feed that went from 7 a.m. to 7 p.m. In addition to this, she would eat a fiber-restricted diet. However, the food would come back out of her G-tube. The patient spends majority of her day nauseous or vomiting and had a weight loss of 14 to 15 pounds in 1 week prior to admission. Some secondary diseases that patient ML had include leukocytosis, hypothyroidism, anemia in the neoplastic disease, malignant neoplasm of the ovary, short bowel obstruction, secondary malignant neoplasm of the liver, retroperitoneum, and peritoneum. She had a slow transit constipation, septic shock, acute colitis, and hyponatremia. So what is the pathology? Well, the American Cancer Society says that duodenal adenocarcinoma is an extremely rare and difficult to diagnose cancer. This will account for 1/3 of all small intestine cancers. What is it? Where's the pathology? The exact pathology is unknown. Some thoughts are that the changes in DNA turn the oncogenes to turn on or off the tumor suppressing genes. So when the tumor suppressor genes are not working properly, they're not able to repair the damaged DNA cells, and gene mutations begin to pass on to 1 cell and then 2 cells and thus forward. It's thought that the growth begins on the gland cells lining the inside of the intestines, specifically on the ampulla of Vater. And lastly, the small growth grows into a polyp, and the more growth, it goes from 1 polyp to 2 polyps, and that will lead to the cancer. What are your risk factors? Unfortunately, most are out of your control. Genetics plays a large role. Things like Crohn's disease, celiac disease, FAP, Lynch, all of the syndromes, cystic fibrosis, are all genetics. Additionally, being a woman of African American descent or having advanced age around 60 to 70 are all genetic risk factors. In relation to Crohn's disease, it's thought that the chronic inflammation releases cytokines that interact with the cell's surface receptors, and then they target genes that promote the cancer genes. Additionally, in celiac disease, some of the lymphocytes infiltrate and creates immunological disruption, damaging the epithelial cells and form pre-malignant changes in the cell lining. Well, what worsens this? Some things through your diet can give you an increased risk factor. Alcohol consumption, smoking, consuming high amounts of sugar, consuming refined carbohydrates, red meats, and consuming smoked foods all play a role in an increased risk factor. What are the symptoms? Initially, as you would guess, since it's hard to diagnose, the symptoms are non-specific to the disease. Some common symptoms related to the small intestine cancer include abdominal pain that will get worse after eating, nausea, vomiting, unintended weight loss, fatigue, dark-colored stool, that's related to the blood in the intestines, a low blood count, anemia, and jaundice. Tests and exams that should be done in order to diagnose duodenal adenocarcinoma include a complete blood count, barium X-ray, endocyclus, an endoscopy, a CT scan, and an MRI scan. A complete blood count measures the level of red blood cells, white blood cells, and platelets because small intestine cancer often causes bleeds into the intestine. The barium X-ray is used to look for tumors within the GI tract. The endocyclus will give more detailed visuals than the barium X-ray by passing a thin tube into the intestines. An endoscopy is a biopsy of any suspicious tissue to determine if the cancer is present. A CT scan is an option that can be done if there's abdominal pain, allowing something like an obstruction to be seen. And then an MRI scan can be used to show detail within the soft tissue. What are your treatment options if you're diagnosed with duodenal adenocarcinoma? You can have surgery, chemotherapy, and/or radiation. Typically, if the cancer is located in the duodenum, a Whipple procedure will be done. If the cancer is in another part of the intestine, they can give a resection for part of it. And lastly, for people with unresectable cancers, surgery may still be an option to block treated intestines. The palliative surgery can remove the symptoms of nausea and vomiting and abdominal pain. Additionally, most patients will need to undergo chemotherapy or radiation. For patients with unresectable tumors, chemotherapy can be done, or they might become a good candidate for a clinical trial. What is your prognosis with adenocarcinoma? There is a 5-year overall survival rate. As the stages progress, typically your chance of survival decreases, going from 70%, 55, 30, to 5 to 10%. The main prognosis factor for small bowel adenocarcinoma is the number of lymph nodes compared to the number of positive lymph nodes. How is this relevant to nutrition? Where does an RD play a role in this? Well, in many cancer patients, anorexia-cachexia syndrome is a huge issue. That can be seen in advanced cancer patients who experience weight loss, lethargy, reduced appetite, nausea, and early weakness. Weight loss typically looks to predict the overall survival and tends to trend lower in chemotherapy response rates. Patients can require up to 30 to 35 kcals of kilogram per body weight to meet their energy requirements. Fluid is also determined by the same energy requirements. Additionally, protein intake goes from 1 kilogram of body weight up to 1.5 per day. Lastly, and we said that this is more common in 60 to 70-year-old patients. Therefore, it's important to look at the critically ill patients. Their protein needs can be higher, as evidenced by 1.25 to 1.5, since they're more likely to have an anabolic response. The patient M.L. was receiving the current medications: famotidine, levothyroxine, medium-chain triglycerides, methadone, piperacillin tazobactam, rivaroxaban, and vancomycin. In order to not bore you with the details to go into these, you're welcome to stay on this slide and read, but I'm going to continue. The initial labs an RD will need to collect are anything out of their range. So I chose to look at creatinine, magnesium, hemoglobin, and albumin. The decreased creatinine is likely related to the decreased skeletal muscle mass. The low magnesium is likely related to the inadequate intake. The patient was receiving repletion per MD at the time of assessment. The patient had a low hemoglobin, which was likely related to her diagnosis of anemia in the neoplastic disease. Lastly, the patient's albumin was low, which can suggest moderate visceral protein depletion and inflammation. So, I was able to identify that malnutrition was at play here. The patient had greater than a 5% weight loss in 1 month. To be specific, there was a 14% weight loss in 1 week. The patient had less than a 75% energy intake compared to her estimated needs for greater than 1 month, and the patient had severe muscle and subcutaneous fat wasting. Given this information, the patient did meet the criteria for malnutrition under Aspen's guidelines. So, what can we do? After hospital admittance, the nutrition department was consulted for the proper tube feed regimen. First, it was determined that the patient would require approximately 1,250 to 1,500 kcal and about 60 to 70 grams of protein to meet her estimated needs. Upon the initial assessment, the patient was only meeting around 65% of her estimated needs. The patient reported that she would eat and then food would be drained from her G-tube. All nutrients were being provided from her tube feed order, and any food given orally was not included. The diet order the patient adhered to while present in the hospital included this. The patient began on a general fiber-restricted diet in order to avoid clogging the G-tube. The patient continued to receive Vivinex at 70 milliliters an hour for 12 hours between the hours of 7 a.m. and 7 p.m. Additionally, here are the changes we made. There was an inclusion of Prostat twice daily to provide 200 kcal and 30 grams of protein. And there was an addition of 15 grams of MCT oil given 3 times a day to provide 345 kcals. The patient was also educated on how to include MCT oil to her current tube feed order to continue to meet her needs when discharged. The progress. During the patient's stay, the tube feed stabilized and patient ML was able to meet 100% of her estimated nutrient needs. The patient denied feelings of nausea, vomiting, diarrhea, and abdominal pain quickly after being admitted, and the patient was treated with IV antibiotics and pain control. Unfortunately, per infectious disease, it's believed that the leukocytosis was related to progressive malignancy rather than infection. So, once the patient was stabilized, she was discharged to home on an oral dilaudid to help manage the pain. Again, the patient has a poor prognosis, but she's wishing to continue outpatient palliative care. When the patient left, I decided to look at a few more factors. Her weight was able to stabilize. Considering her severe malnourishment, it's a good thing that she had a stabilizing weight. However, refeeding syndrome can be a serious consequence of increased tube feeds, so it was important to continue to monitor for any changes in her potassium, phosphorus, and magnesium. Additionally, her creatinine looked better. The albumin decreased, and the magnesium increased. Levels of creatinine can be varied due to decreased skeletal muscle mass, which was likely linked to cancer. So increasing nutrients into the tube feed did help this. Next, the levels of albumin vary in relation to moderate visceral protein depletion and inflammation. They're not a perfect biomarker for marks of malnutrition, but it could show that she had increased inflammation the next time the labs were drawn. Lastly, the levels of magnesium varied because they were closely monitored and replenished per the physician order, and there was no nutrition at play here. The discharge plan, the patient could benefit from an outpatient registered dietitian counseling. Unfortunately, there's no information on the patient's progress post-discharge available at this time. There's no knowledge that she had joined our outpatient services. However, there was inpatient counseling given to her on including MCT oil to her tube feed at home. Here are some of the references that I used. And if you guys have any questions, I'm here to answer everything. Thank you so much.